Hello, and welcome to this presentation on an introduction to contrast-enhanced ultrasound for abdominal applications. My name is Cyndi Peterson, and I have been working with ultrasound contrast agents in radiology setting since 1997. We initially started using contrast agents in clinical trials and then continued to use them outside of trials. And so what you'll be seeing is based on the experience that I have gained during that time. Ultrasound contrast agents were approved in the United States in the early 21st century for evaluation of cardiac ultrasound, and in particular to opacify the left ventricular border. However, radiology applications were not approved in the U.S. until the year 2016. In Canada, Europe, and Asia, the approval for radiology applications, and in particular the abdomen, came around the same time the United States had cardiology approval. Therefore, we are slightly behind the curve in the United States. However, we are catching up rapidly. The objectives for this presentation are that the attendees understand what ultrasound contrast agents are, how they work, why we use them in non-cardiac applications, and how we can use them to better image patients, especially in the abdomen. Ultrasound contrast agents are gas-filled microbubbles that have a gas within the core and a lipid or an albumin shell. The exact composition depends upon the agent that is being used. There have been a few times in my ultrasound career that I have stopped and looked at a radiologist and thought, "You want me to do what?" One of these was transvaginal ultrasound. When we first started performing transvaginal, the thought of placing the transducer into the vagina was a foreign concept, but now it is standard of care. Another time that I had that same thought was when we started using ultrasound contrast agents, and Dr. Richard Barr, with whom I've worked for many years, said, "We're going to inject air into a patient's vein." The radiographer in me thought that air in a vein is bad. However, the reason that ultrasound contrast agents are effective is because the microbubble is smaller than the red blood cell. Therefore, the bubbles do not get trapped in pulmonary circulation, they do not aggregate, and there is no risk to the patient. These contrast agents are injected intravenously in a peripheral vein, typically a vein in the antecubital space or elsewhere in the arm. However, we can use veins in hands and feet. We can also use an indwelling IV if one exists. These contrast agents are blood pool agents. They remain within the blood vessels and give us a very strong signal wherever contrast agents are present. They are not excreted into the collecting system of the kidneys as CT contrast agents are. And we can see that we will have a distribution of blood cells and contrast agent bubbles within the patient's vessel. The contrast agent microbubbles oscillate in the sound field, and as they do, they increase our signal-to-noise ratio, meaning that everywhere we have circulation, we have contrast microbubbles, and therefore we have a stronger signal that is produced. As the microbubbles oscillate, they produce nonlinear frequencies or harmonic frequencies. When we're using very low power at a mechanical index of less than 0.1, we have somewhat of a linear response. That means that the microbubbles will oscillate, but they will oscillate in such a way that they don't give off many harmonic frequencies. When we increase the mechanical index slightly, we start to have a nonlinear response, meaning that we have greater oscillations of the microbubbles. And as you can see in this graphic, the oscillations are slightly pronounced. If we have the mechanical index set higher, we will have larger oscillations yet. But the problem here is that the oscillations become so strong that the shell cannot withstand the oscillations, and the microbubbles then will burst. There are very specific times that we might want to use a high power to burst the bubbles, but overall we use a very low mechanical index to allow for optimization and use of the bubbles rather than bubble destruction. All ultrasound equipment vendors have contrast-specific software that has been developed. And if there is an advantage in radiology to the delay in approval, it is that we have had a lot of time to work with the vendors to make the equipment ready for abdominal applications of contrast. Different vendors use different platforms, and we may have phase inversion or pulse inversion or amplitude modulation, but the goal of each contrast-specific software package is to display the harmonic bubble signal and not display any of the underlying fundamental information. Therefore, when we optimize our images in a non-cardiac setting, our image settings are agent-specific rather than organ-specific. And going from agent to agent, there is not a large difference. So we can use the already existing contrast software with essentially any agent. Every system now has a contrast button, and when you activate that contrast button, there are already optimized presets for use of contrast agents. I want to give you a few practical points before we start to look at some images. We're going to use low MI continuous scanning. The image will initially be black on the side where we're going to look at contrast agents prior to injection. We're usually going to use a dual screen because this allows us to have a point of reference. Because one side is already black, we want to be sure that we're in the right plane when we do the injection. We will have the transducer in place at the time of injection, and this is really important because we have a very short time window, about 10 to 20 seconds after injection, before the contrast agent will appear on the image. So we need to be sure that our transducer is in place and where we want to evaluate a lesion prior to the time the injection actually occurs. We also want to have that lesion in plane, meaning visible shallow respirations. We characterize a lesion over a long period of time, 90 seconds or longer, and we know that patients cannot hold their breath for that long. So we are going to want to choose a plane, usually a sagittal or an oblique plane, in which the patient can breathe and we can see the lesion as the patient is breathing. This means that we need to do a little bit of planning prior to the actual injection to be sure that we're going to have the optimal visualization of the lesion once the injection has taken place. We can set our Cyndi clip for up to 3 minutes in length, and there are times when we're going to want to evaluate a lesion for a longer period of time than others. It depends on the pathology we are visualizing. And if your system has a focus or a focal zone, we're going to place that at the most posterior part of the image because we do not want to burst bubbles at the level of the focal zone. When we put our contrast software on, or when we activate our contrast software, the image will appear as you see on the screen. The left side is the contrast side, and it is intentionally suppressing all of the fundamental information. On the right side, we have a reconstructed B-mode image. The quality of that reconstructed B-mode image is never as good as the quality on our grayscale imaging. So that right side serves as a point of reference only. Ultrasound contrast agents are known to be safe agents. The safety profiles have been established, and they have a short half-life. With the doses we use for abdominal imaging, the contrast agent will persist in the patient's system, usually for about 4 to 5 minutes. That means that we can use multiple injections. If we have more than one lesion to characterize, or if we have a failed injection, we can administer a second injection if needed. So why would we use contrast agents in the abdomen? It is different than in cardiology. In cardiology, the contrast agents are used to improve a suboptimal study. In radiology, we don't use them for that purpose. Instead, we are using them to characterize lesions, typically liver lesions or renal lesions, but they can be used to characterize a number of lesions. We can assess whether ablative procedures have been successful or not by looking at blood flow. We can look at pediatric patients to examine for vesicoureteral reflux and avoid radiating those patients with voiding cystourethograms. We can look at ischemic conditions and evaluate with real-time imaging and many more. The indications and applications of ultrasound contrast agents will continue to grow. There are certain patients who can benefit from contrast-enhanced ultrasound, and a large population of these patients in the abdomen are patients who cannot have CT or MRI contrast. Patients who are allergic to iodinated contrast media cannot have CT contrast. But in addition, patients who have renal insufficiency cannot have CT contrast due to its nephrotoxic properties and cannot have MRI contrast because MRI contrast is excreted through the kidney and through the urinary system. So therefore, ultrasound contrast agents are a good choice in these patients because they are not excreted through the kidneys. In addition, in patients who have had prior imaging, either prior ultrasound examinations or CT or MRI examinations in which a lesion has not been characterized, we have an application as well. We know in pediatric patients, the optimal imaging exam should not involve radiation. That is the image gently directive. So ultrasound contrast agents can provide additional information in these patients. We do not need to consciously sedate patients for ultrasound exams typically. And I want to make a comment about dosing. The adult dose of contrast agents in the abdomen is the same for all adults. It can vary slightly depending on the newness of the ultrasound equipment. Newer equipment can typically use lower doses, but it is the same throughout adults. That is not true in children, and certain contrast agents have weight-based dosing for pediatric patients. If we have patients who have had an interventional procedure, either a radiofrequency ablation or a cryoablation or a microwave ablation, patients who have had endovascular aortic stent grafts, we can evaluate for the presence or absence of blood flow in these patients as well. And in patients who have ischemic defects, such as infarcts, we can provide a real-time assessment of blood flow in these patients. There is reimbursement for ultrasound contrast agents in the radiology setting. As of January 1st, 2019, a new CPT code was enacted, and this CPT code is for ultrasound evaluation of non-cardiac lesions. And there is a code for the first lesion that is evaluated. There is another code if we evaluate more than one lesion in the same patient. In addition, there is reimbursement for the agent that is administered as well. I want to talk about some particular applications, and we're going to talk primarily about liver and kidney. Before we actually look at ultrasound images with contrast, let's review the blood supply to the liver. The liver has a dual blood supply. The hepatic artery brings blood to the liver first, and then the portal venous system drains blood from the intestines and brings that blood to the liver secondarily. This blood will be distributed throughout the hepatocytes. This leads to three phases that we see on multiphasic CT as well as on ultrasound contrast. We have a hepatic arterial phase, followed by a portal venous phase, followed by a late phase, which is sometimes referred to as an equilibrium phase as well. On contrast-enhanced CT, we can see a patient without contrast. So notice that none of the vessels are enhanced and the hepatic and splenic parenchyma is not enhanced as well. In the arterial phase, we can see profound enhancement in some of the arterial structures. In the portal venous phase, notice that we see more contrast within the portal veins and less within some of the arterial structures. And then in the late phase, we can still see enhancement of the parenchyma, but we no longer have distinct vessels. The same is true with contrast-enhanced ultrasound. On your upper left, we can see the arterial phase, so we see some of the arteries that are highlighted in the liver. And again, notice that on the left side, we're only listening for those contrast bubbles, so we only see the contrast. And so we see the arterial phase on your upper left. On the upper right, we see the portal venous phase, and now we can start to see flow in the portal veins. And the bottom image shows late phase or equilibrium. We no longer see a large amount of contrast in the vessels, but now we can see what we refer to as a parenchymal blush within the liver tissue. There have been guidelines established for when we see blood flow. The arterial phase in the liver starts about 10 to 20 seconds after injection, and that's why we need to have that transducer in place at the time of injection. The arterial phase ends about 30 to 45 seconds after the injection, at which point the portal venous phase commences. The portal venous phase can last up to 2 minutes after the injection, at which time the late phase commences. And those bubbles will last, as I said, for about 4 to 5 or even 6 minutes after injection. Do not get stressed about the numbers because we will see lesions behave differently depending upon what phase of vascular imaging we are examining. Okay, and we'll see what that means as we look at some clips. This is a normal liver, and as we look at this liver, I want you to notice on the left side again, we have all of that fundamental information suppressed, and we are just listening for bubbles. There is a timer on every system, and in this system it is up in the right-hand corner. It tells you there were about 21 seconds after injection. We're starting to see the arterial flow. So here we can see the hepatic arteries highlighting in this patient. And as we continue, we're just going to watch the vascular enhancement of this liver. Now we can see the portal vein a little bit more clearly. And notice that we're starting to see more portal venous flow within the liver, and the liver parenchyma is starting to highlight as well, or enhance. Over time, those vessels will disappear, and we will see that late phase parenchymal blush that we saw on the previous slide. Every system has a timer, and we start that timer at the time that the flush begins, so we have consistent evaluation of the contrast parameters. We can characterize the type of liver lesion based on its enhancement patterns. Benign lesions will remain enhanced in the late phase, and malignant lesions will wash out. The type of enhancement in the early phase, the arterial phase, depends on the type of lesion, if it's a benign lesion. If we have an FNH, we will see central stellate vessels. If we have a hemangioma, we will see centripetal fill-in. In malignant lesions, we sometimes see an irregular vessel pattern. Malignant lesions will have a rapid enhancement pattern with rapid washout. That is one of the most important factors to remember in evaluation of liver lesions, that benign lesions remain enhanced in the late phase, and malignant lesions, because they take up that contrast and then dump it off, will wash out. Hemangiomas are common liver masses that on CT and MRI will fill from the outside in. We can use what we already know from CT and MRI contrast and translate that to ultrasound. In this image, you can see a series of 3 blue arrows. The top image shows the arterial phase, and notice that the center of the lesion is not enhanced. When we see something that is anechoic or looks black essentially on a contrast image, that does not necessarily mean there is fluid present. That means that there is no flow in that lesion, because everywhere we see contrast, we're going to see enhancement. Everywhere we see enhancement, we see perfusion. So when we see flow, we're going to see what looks like a more echogenic area. So in the top image, we can see flow or enhancement around the outside of the lesion and nothing in the center of the lesion. But the second image is taken about 20 seconds later, and we can see enhancement in the center of the lesion. The bottom image is taken about 30 seconds after the second image, and now we can see that entire lesion is enhanced. So the lesion has enhanced from the outside in, or centripetally. That is characteristic of a hemangioma on contrast-enhanced ultrasound. I don't know how many sonographers can say with confidence that they have imaged an FNH without contrast ultrasound. This becomes very easily distinguishable with contrast, though. This patient has a subtle liver lesion. If you look at the grayscale image, you can see a slight contour difference in this case, but it is slight. So pretty subtle image that was seen on a CT urogram. If we look at the top contrast image in the center where the arrow is pointing, there is a starfish or stellate appearing area. We will see fill-in from the inside to the outside with the stellate appearance in an FNH. The bottom image is 2.5 minutes after injection, and if you look at the lesion where the arrow is pointing, compared to the remainder of the liver, the lesion remains enhanced. This is characteristic of a benign lesion. I think it is important, however, to see what washout looks like, because if you're looking for washout versus sustained enhancement, you need to know what washout looks like. So this is a patient with metastatic disease of the liver, and we are going to watch this patient. This is about 10 seconds after injection currently. We can see a lesion in the near field on our grayscale image, and notice as the patient breathes, the lesion stays in plane. That's what we want to have happen. You can see the lesion enhancing in the near field, as well as an additional lesion further from the transducer, and there's one a little more superiorly that comes in and out as the patient breathes. This patient is breathing shallowly, no held respiration in this case, and we saw that lesion enhance, but notice now that the lesion has less contrast than surrounding tissue. That is washout. At this point, and especially maybe 10 seconds forward, we can sweep the liver because we know that if it is a malignant lesion, by this time frame, it will have washed out. So we can start to look for other washed out areas within the liver. In metastases, then, we will have a rapid wash-in, as we just saw, and we will see washout. On the left, we can see the enhancing lesion closest to the transducer, and in the same patient, about 90 seconds after injection, we can see multiple lesions that have washed out. This is characteristic of a malignancy. And if we have a rapid washout, that is characteristic of a metastatic lesion. Hepatocellular carcinomas also have a rapid wash-in, and sometimes we will see some irregular vessels along with an HCC, but these lesions can take longer to wash out. On your left, you can see an image 30 seconds after the injection, and there is profound enhancement, marked enhancement in that lesion. However, 2 minutes after the injection, on your right, we can see less contrast in that liver lesion than in surrounding tissue. This is an HCC. They take longer to wash out. When we image the kidneys with contrast, we have a slightly different flow pattern to consider. We have a single artery and a single vein that supply and drain the kidneys. Therefore, there are no renal vascular phases like we have in the liver. So we're going to watch the wash-in and the wash-out of the contrast. The medullary pyramids and the calyces are not well perfused on contrast ultrasound, and anything that doesn't have blood flow will appear as anechoic. This is a normal kidney, and as we watch this patient, we're also going to see the liver enhance, but we're going to pay particular attention to the kidney. So we can see that the kidney is all enhancing at the same time. We can see that the vessels have slightly greater enhancement in this case. And if we look at the region of the medullary pyramids, we can see that they are not well enhanced. They are evenly dispersed, and this can be really helpful when we're trying to determine something like a dromedary hump and a mass. That even disbursement or distribution of the pyramids without contrast can give us clues about the type of pathology in which we are examining. We use ultrasound contrast in looking at kidney lesions, especially when a patient has a complex cystic mass. These are characterized on CT, oftentimes as Bosniak 2 or Bosniak 2F lesions. And these are referred to as indeterminate renal masses and are an excellent application for ultrasound contrast agents in the abdomen. This patient had a complex-looking cyst on grayscale ultrasound. However, there was no flow within on contrast, and we can see that this is a simple renal cyst. The fact that we don't see any contrast within the cyst means that there's no flow. Again, it doesn't mean that that it is fluid-filled necessarily. In this case, however, it is fluid-filled. Renal cell carcinomas have flow post-injection. And in fact, when we have a mass that has flow post-injection, that is suspicious for malignancy, depending on the type of mass. If we have rapid enhancement, we are concerned that we are dealing with a renal cell carcinoma. This is a patient who had a renal mass noted at the superior lateral aspect of the kidney on a CT that was performed without contrast due to the suspicion of kidney stones. There was a slight contour defect in this kidney, and the patient was sent in for contrast imaging. So based on what we have discussed so far, let's take a look at a contrast injection in this patient. This is 7 seconds after the injection. And remember, the contrast gets there pretty quickly. This is at the superior pole of the kidney where we are looking. And notice we can see in this case that this patient has a mass at the superior pole that is enhancing greater than the renal cortex. This is suspicious for a renal cell carcinoma. You can see that the pyramids and collecting structures are not enhancing in this patient, as is typical. This is 20 seconds after the injection. In patients who have had ablation procedures, we can examine for the presence or absence of blood flow. If the patient has had a radiofrequency ablation or a cryoablation, we expect to not see flow in the ablated area. This patient has a left renal tumor that has been ablated, and on the left side of your screen, you can see a blue arrow pointing to the mass. And remember that when we do an ablation procedure, the mass is not removed, it remains in the area in which it was ablated. It will just get smaller over time due to the lack of blood flow. On the contrast enhanced image, the yellow arrow shows that there is no flow to this mass, so the ablation procedure was effective. We can use contrast injection with ultrasound at the time of the ablation to confirm a successful procedure before the patient even leaves the interventional radiology suite or the ultrasound department. We can then follow these patients at intervals to confirm that there is no new tumor vessel growth. In any type of interventional procedure in which there is an expected lack of flow, ultrasound contrast agents can be beneficial. In a patient with an aortic stent graft, we would expect that there's only flow within the graft and that the flow has been excluded within the actual aneurysm. Oftentimes, patients with endografts are followed with contrast-enhanced CT, but ultrasound contrast agents can be an effective way to follow these patients as well. On the slide, the blue arrow points to the area of the lumen of the endograft. We expect to see flow in that area. This patient has a type 1 endoleak, and we can see a large amount of flow in what should be the excluded aneurysmal sac. The yellow arrow points to the flow within the aneurysm and demonstrates the endoleak. We can also use contrast to evaluate flow patterns by looking at particular regions of interest. In doing this, we can generate time intensity curves. These can be generated either on the ultrasound system or offline on a computer. In this example, the yellow region of interest is in a liver lesion, and the green region of interest is in the normal adjacent hepatic parenchyma. When the clip begins, you will see a moving line that shows how long it has been since injection. As the patient breathes, you will notice that our regions of interest are moving, and the equipment vendors have done a very good job of adding breathing tracking to the systems. Notice there's that tiny little line at the bottom moving, showing us that we are about almost 20 seconds after injection. We can see enhancement of the hepatic parenchyma, and the yellow region of interest corresponds to the yellow line that is seen on the graph. This yellow line tells us that we have more enhancement within the lesion than we do within the remaining hepatic parenchyma. This clip takes place over about a 60-second time. And if you remember back to the liver mets that we looked at, we had washout of the liver mets. If we look now at our time intensity curves, we can see that the lesion remains enhanced. And we said earlier that benign lesions remain enhanced. So if we saw that yellow line take a dive and go way below the green line, we would be worried about a malignant lesion. These contrast dynamics can be helpful in times that the interpreting physician wants additional evidence to verify what we see visually. So how do we do this in a radiology setting? First, we have to decide which patient is going to get contrast. Early in the process, this may include discussing the patient with the referring physician. Eventually, the referral pattern will just be that patients are sent in with a script that says contrast-enhanced ultrasound, as happens in our practice. We need to obtain consent, either written or verbal. That depends on the facility as to how that takes place. The patient will need to have an IV, typically no smaller than a 20 gauge. If we have to use a 22 gauge, we're going to inject at a slightly slower pace. This is because the contrast microbubbles are sensitive to pressure. So we do not want to try to force those bubbles through a 25 gauge because we are going to then burst the bubbles and have no contrast effect. As I mentioned, we can use an arm or a hand or even an indwelling IV. We're going to need to activate the drug, and these drugs are shaken to activate them, either shaken by hand or by a device. It depends on the agent that you're using. It is important to have a crash cart in the area in the same way that we do for CT or MRI contrast. Ultrasound contrast agents have a low rate of reported adverse events, but we are still injecting contrast into the patient. So we would not inject without a physician on site, and we would not inject without access to a crash cart like any other medication that is being used. We're going to perform our standard exam and locate the lesion of interest. And it is not a bad idea to actually mark on the patient with a marker where that lesion is. So we're ready to do the contrast portion. We know exactly what the best plane will be to image that lesion. We will activate our contrast-specific software and activate our dual screen if we want to. We need 2 people to inject and scan during an ultrasound contrast examination. It is nice to put the IV in the left arm because that way that side of the bed is for the person injecting and the patient's right side is for the person scanning. But if there's a reason that you cannot use the patient's left arm, for example, the patient has a dialysis fistula or the patient has had surgery for breast cancer in the past, we can use the right arm for the IV as well. The most important thing is to have good venous access. Because the contrast arrives so quickly at the organ of interest, it is virtually impossible for the sonographer to inject, turn the stopcock, administer a flush, and have that transducer at the proper location by the time the contrast arrives. So we need someone else in the room for about 5 minutes maximum. I mentioned the stopcock, so let's talk for a minute about how to inject. If that contrast was activated a while before we're ready to inject, we're going to reactivate the contrast, meaning shaking the vial or the syringe if we need to. We use a 3-way stopcock in our practice, and the area where the stopcock is pointing is what is actually being stopped. So in this photograph, the saline is on the side port, and that is being stopped right now. The contrast is on the straight portion of the stopcock. That is because we do not want those microbubbles to travel around a turn because they are pressure sensitive. We're putting in a very small amount of contrast, so we're going to inject the contrast and follow it by a saline flush. The contrast is injected at a rate of about 1 milliliter per minute, and we follow immediately with the saline flush at the same rate. That flush is going to push that small amount of contrast along the vein so we can see perfusion. We're going to start our contrast timer that we have seen in our various clips. We start that at the beginning of the saline flush. We're also going to start our clip save at that time so we don't miss any contrast bubbles coming in. And then we're going to collect our ultrasound images, and most often we keep that transducer in the same place to characterize the lesion, but we may want to sweep the liver if we're looking for additional metastases, or we may want to sweep through a complex renal cyst to look for flow and septations. We want that lesion in plane as we're scanning, and we want the patient to practice shallow breathing. If we need to, we can do another injection right at that time. And if we don't need another injection, or when we don't need another injection, we're going to end the study. At that point, we can go back to our Cyndi clip and acquire still images to provide the radiologist with additional information. And if we're looking at a hemangioma, we may want to take various images of that centripetal fill-in. If we're looking at FNH, we may want to take images of that stellate appearance. Sometimes your eye will catch additional things as you are looking at those images in review. At that point, we can remove the IV and terminate the study and send the patient on his or her way. In order to implement contrast-enhanced ultrasound in a radiology setting, we need a team approach. This is a paradigm shift in radiology ultrasound. Not as much of a paradigm shift exists for radiologists because they are accustomed to interpreting CT and MRI images with contrast. And as I said, for the most part, the enhancement patterns are very similar. For sonographers, however, we do have to start to think differently. We need to recognize patterns of enhancement. We need to understand scanning techniques. However, these scanning techniques are pretty well elucidated now, which is helpful. It does add a few minutes to the exam, but not very long. And we have this non-invasive mindset in ultrasound, which is interesting considering we do endocavitary exams. We do transvaginal and transrectal, which are somewhat invasive. So that non-invasive mindset needs to go away as well due to the number of patients that can benefit from contrast-enhanced ultrasound. One of the sticking points, even after almost 20 years in cardiology, is that we need to have someone to inject. So in certain states, sonographers cannot inject contrast. Therefore, we need either a nurse or a different imaging technologist, or in states in which the sonographers can inject contrast, and we have sonographers who are IV trained, where we need someone to place the IV as well as to inject the contrast. In conclusion, contrast-enhanced ultrasound can be beneficial to many patients in multiple types of exam in a non-cardiology setting. We need appropriate clinician education and training, and therefore, I appreciate your attention during this presentation. Thank you.